Good morning. Thank you very much for the invitation. On behalf of the heart team at Hygeia Hospital, we'll be discussing about imaging for tricuspid interventions and particularly as a guiding primer. So the primary modality for tricuspid repair is edge-to-edge repair, as we saw with the two devices that we have, the TriClip and the Pascal, which both do essentially the same thing. They create a permanent coaptation between the septal and either the anterior or the posterior leaflets, and that creates a reduction in the regurgitant orifice and regurgitation of the valve. So it's very important to understand these specifics when we are engaging a patient for tricuspid intervention, and particularly, especially for edge-to-edge repair, to understand the leaflet length and mobility, the number of the leaflets, whether there are significant coaptation gaps, the location of the regurgitant jets, whether there's any pacemaker leads, and with all of these informations to devise a plan of how to proceed, what would be our landing zone, the orientation of the device, and the number of the devices that we may need to implant. In particular, the tools of the trade here are 3D transesophageal echo. Biplane modality is very important, and we use it heavily on our interventions. Here we can scan the valve from anterior to posterior and assess leaflet length, leaflet mobility, coaptation gaps, and correlating that with color, without color, to see exactly where we need to focus on our attention. The transgastric views are very important as well for the fact that they delineate the number of the leaflets. And we know, as we saw before, that only about 50% of patients will have the three leaflet morphology, with about 30% who have two posterior scallops and other iterations in lesser percentages. 3D will also help us understand the morphology of the valve from a transgastric approach, and also to try to understand the coaptation zones that we need to focus on. You can see the septal anterior coaptation zone here, which will imply that our device would be like a 2-8 configuration, versus septal posterior, which would be like a 3-9 configuration for our devices. I will skip over these images. The live 3D image of the tricuspid valve is very important because it can give us a clear view, a nice view of the valve morphology, number of leaflets, and it's easy to obtain this. And with this, having the marker of the aortic valve to signify where the septal anterior commissure is, this will be the anterior leaflet, posterior leaflet, and septal leaflet back there. It's very important, and it's being used heavily in interventions, is multiplanar reconstruction, where we take a 3D image as we have here, and we analyze it to RV inflow view, where the aortic valve sits here, and here we orient ourselves to anterior and posterior. This is the long axis view, septal and lateral, and this is the short axis view with the aortic valve at 5 o'clock. That would also give us something like a transgastric view. And with these, we can easily discuss and communicate in the hybrid OR. So let's look at a case example of a patient with severe atrial functional TEER, referred for intervention. She's very symptomatic. So we see here that when we scan the valve, the jet is central from the central area of the valve. Transgastric seems to show a tri-leaflet anatomy with a jet that's in the center of the valve and maybe slightly septal posterior. 3D imaging also confirms the three-scallop anatomy of the valve. And when we scan from a mid-esophageal view, we can assess the leaflet lengths, in particular to see that what the septal and the lateral leaflet is in particular areas. And our plan here would be for one device, in particular maybe a 3-9 configuration for septal posterior, or we might opt for a 2-8 configuration if we go for septal anterior, but something in the middle, not deep in the commissures. This is a modified bicaval view with 3D imaging. We can see down here the entry of the guide sheath into the right atrium. The septum is here, so this is septal, this is lateral. We can see at the background the tricuspid valve, septal leaflet, anterior leaflet, posterior leaflet. And as the device comes out, this is a Pascal ACE device. We can see it nicely. And afterwards, we move about to the tricuspid valve, and we assess with biplane imaging our position and trajectory. We want to be over the main color jet. After we assess this, we can also utilize MPR at this stage to assess our position and trajectory. We can see here that we have a slightly anterior trajectory, which we need to correct. Our position is also more posterior here, so those things we can correct. And now we move more at the center of the valve, and we're over the main color jet here. And with this, we can also guide our clocking, utilizing one image for all information. Here we moved that below the valve, and we're focusing on the independent clasping of the lateral leaflet first, and we can see it here. And then we move on to the septal leaflet here for clasping. We close the device. We have an initially good result. We want to confirm good leaflet insertion. We do that in transgastric views. We see that the clocking is good. But we see here that septal leaflet goes very shallow inside the device, so we have to correct for that. Here we do optimization of actually both leaflets, the lateral leaflet first, and then we move on to the septal leaflet up here, and here we engage it independently. Again, here we can close our device during transgastric to understand how much leaflet we have. I think we're going to optimize once more the lateral leaflet, the septal leaflet here, because we see this lateral septal leaflet outside. So we reopen, engage again, and it's very important to image this phase of the procedure, because this is a key point of understanding that we have enough leaflet insertion in our device. So documenting the grasping of the leaflets. And with this, we are more happy with our position and our leaflet insertion. Now we see that the leaflets go all the way to the center of the valve of the device, and with that we released it, and we have this final result, a very good reduction. Again, for difficult imaging cases, we use intracardiac echo with 4D, which is coming into play. At this point, it is used adjunctively, but in the future, it might be the prime modality for its wedge repair. And in this particular view here, we can see septal and lateral leaflets very nicely here. We can understand that the septal leaflet is on our device. And then here is the closing of the device. And here's the second device next to it. We are positioning septal here, lateral here. There's also pacemaker wire nearby. And this can be very helpful, especially in very difficult imaging cases when TOA is not very helpful. So for difficult cases that we are opting for valve replacement, like this patient here, an elderly patient with pacemaker-induced torrential tricuspid regurgitation. And we see here that it's truly torrential regurgitation. We can see scanning of the valve that anteroseptally we don't have any significant gaps, but when we move up to the center of the valve here, gaps it's about 9 millimeters, and we go more prosteroseptal, the gap becomes 15 millimeters. We always assess right ventricular function in these cases when we're going to do tricuspid replacement to see if the right ventricle can handle it. Again, tricuspid short axis views here show that the impingement of the leaflet of the pacemaker wire on the septal leaflet that creates torrential TR. So here we opted for an evoke valve, number 48 millimeters. And again, on the day of the procedure, we reassess the annulus area to make sure there's no change from overdiuresis or anything like that that may change the size of our selected device. The first step is to advance an extra small safari wire at the RV apex, and we watch that on echo to make sure that it's truly at the apex and not behind the papillary muscle. And then we advance the deliver system of the evoke valve very gradually. Once we're in position, we've switched to MPR. The majority of the imaging here is multiplanar reconstructions from a 3D image. We analyze it into this inflow-outflow view, this lateral long axis view here, and the short axis view here, where we want to position our system in the center of the valve, maybe slightly septal to the center. And here we do a very gradual withdrawal of the capsule to create this capsule gap. And with that, we can assess our initial depth before proceeding to open the anchors. We want to make sure that we're well below the annulus of the valve and the coaptation zone of the leaflets with our capsule gap, but not too deep to engage, to get in trouble with the papillary muscles in the subvalvular apparatus. And with that, once we have that confirmed, then we will slightly open the capsule, and here we have 45 degrees, and then we're going to move on to 90 degrees of opening of the anchors. And here we start our effort to assess each one of the individual 9 anchors that we have for engagement of the leaflets. And in particular, we use this MPR modality, and we select, for instance, this green plane, and we're going to start rotating it clockwise to try to understand all anchors that they have leaflet engagement. Here we move to about, this is the anchor at 7 o'clock, and we see here in this view that we have leaflet engaging over the anchor. We will do this in this area here. There's a shadow, so we won't be able to see, but we do see a leaflet over our anchor. We move on to the anchor at 10 o'clock here. And again, we look at this view to make sure that we have leaflet engagement. And we'll do this sequentially for all 9 anchors all around. And in case we have any questions, we can move to biplane imaging, especially for these posterior anchors. We can do it from transgastric view, and we can biplane and make sure that we have leaflet engagement in this area as well. And after that, we can do our atrial flip and our ventricular expansion. Again, here, less potential for movements, but still, again, we would like to do our spinning again, starting from this anchor down here, making sure that there's leaflet engagement, same all across, all around, before we decide to further do the atrial expansion and final release of the valve here. Imaging afterwards confirms the good position and lack of any paravalvular leaks from the valve, especially if you have pacemaker wire. Sometimes you may have a small leak next to it. We confirm that the leaflet mobility looks good, and we document that to have that something to compare for the future. Immediate assessment of RV function is also among the things we have to do. So in summary, transcatheter interventions are becoming primarily very important therapeutic options for many of our patients. They're in the guidelines as a 2B indication to consider the 2A indication to consider them in patients who are significantly symptomatic, and that includes both repair and replacement techniques. 3D transesophageal echo, especially with the new modalities of real-time NPR, is very important in our procedures and facilitate accurate positioning and deployment of devices. And intracardiac echo is going to play a very important role in the future for these interventions. And with that, I would like to thank you for your attention.
Yeah, well, great. I was going to ask a little bit about the eyes. Am I the only one who considers these images a bit fuzzy?
They're fuzzy. They're fuzzy. I agree.
What's happening with that? When are we getting better eyes images? Because it's difficult to make it default if it's fuzzy.
Correct. Yes, that's true. It's technology that's evolving. This is the previous generation of the particular platform. And now it has evolved into a next generation. And again, there's multiple vendors at this point that we have to consider for ICE, for 4D ICE. But again, these things evolve and improve over time. So we anticipate that ICE will play a significant role, in especially edge-to-edge repair.
Well, actually, this problem is a physical problem. It's a problem related to the frequency. The frequency with the intravascular echo is pretty high. So there's some refraction which adds noise. It's a problem which comes back to the era of Professor Bombs in Thorax Center, mid-80s, when they tried, it was the first effort, Yorgos, to organize intravascular echo at that time.
I mean, Dr. Shuvy is going to have an interesting question. I'm asking, what do you think AI can help us here? Because we have so many ways to see the heart. We have a CT, we have a pre-procedure, so many. And somehow, when we go into a procedure, we only see whatever is live. There's no way to incorporate all this knowledge. It's a knowledge. We have all these images, except in the basement, in some server or whatever other modality. We see something. Yeah. But I think if we had an ability to say, you know what, whatever we see is really what we already know from before, which kind of looks this way, then if we integrate it, we may actually, from what we already have, we can do a better image.
Correct. I totally agree with you that, imaging, the real difficulty with tricuspid is imaging and understanding where we are and understanding our planes and our trajectories and how we engage the valve. And my analogy is like a pilot who's flying a plane manually all the way from Athens to New York. That's the way we do edge-to-edge repair or tricuspid intervention these days. There's no assistance from AI, as you mentioned, or some sort of other modality to help us guide us in our assessment of position, trajectory, engagement, and all that. So we really need, there's a lot to see about that.
One question about planning the tricuspid TEER procedure. We know that the surgical concept of treating the tricuspid is to gain annuloplasty. Do you routinely evaluate the annulus before, during, and after the procedure? Do you look at reduction of the annulus is one of your targets during the procedure? And if yes, how do you get it?
That's a very difficult question. In the mitral space, we've been able to do that and replicate and understand that, yeah, there is annuloplasty effect of edge repair, especially for the anterior-posterior diameter of the valve. For the tricuspid, it's more difficult because the software to assess tricuspid annulus is not as robust as in the mitral. So there is a lot of possibility of bias in our measurements, knowing that there's a device there. So I wonder, the only way I would consider that is maybe doing a CT study or an MRI study to try to be more accurate, whether we truly have an annuloplasty effect or not. But I'm sure some degree of annuloplasty effect is created. But I think it's more difficult to measure by TOE.
Just one comment, and from my experience, we know that there is, unfortunately, recurrence of TR after tricuspid TEER. We know from data that at 1 year, we have almost 25% of severe TR in patients that were initially treated with a good result.
Mm-hmm.
From our experience, we aim to get a reduction in the annulus, and therefore, in almost all our cases, we're doing a Clover technique.
Mm-hmm.
We took in the anteroseptal and also the posteroseptal device, and by this, we feel that we get a better annular reduction and better long-term.
So by default, in a sense, like...
In almost all cases,
okay,
we put two devices, one in the anteroseptal, one in the posteroseptal, creating a Clover, and we know, from our experience, it decreased the rate of recurrence of TR after the procedure.
So even if you have a good result with an initial device, anteroseptal, you may put a second one just to support an annuloplasty effect, then, because so you won't have recurrence. That's very important.
Actually, it's a very important task, an issue what Dr. Shuvy mentioned.